Good evening, and welcome to this session of the Tourette Association's virtual conference. I am Amethyst Johnson Creek, Manager of Information and Referral Services at the Tourette Association of America. Thank you for joining us tonight for Tourette 101 for the Community Practitioner, Identifying Tic Disorders Distinct from Other Conditions. We want to thank our platinum sponsors, Warner Fund and Pharma, as well as all of our donors and supporters for making this free conference possible. To support future educational programming such as this, please visit our website, tourette.org/donate to make a contribution today. During this session, we will be happy to hear from you. Please submit your questions or comments using the question pane on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. It is my pleasure to introduce our presenter, Dr. Keith A. Coffman. He is the director of the Tourette Syndrome Center of Excellence at Children's Mercy Hospital in Kansas City, Missouri. Dr. Coffman is also a co-chair of the TAA Medical Advisory Board. Dr. Coffman, he is a board certified in child neurology and neurodevelopmental disabilities. Thank you for being here tonight, Dr. Coffman. You can begin your presentation.
My pleasure. Okay, so this statement says that I don't have any financial interest, and we're not even talking about any products here. So how to diagnose movement disorders? So my mentor, Dr. Michael Painter, said neurology is all about history. If you don't know what a patient has after taking their history, you need more history. So we're going to go through a number of different cases today. So I'll guide you through many cases of involuntary movements and other behaviors in children, illustrate the key pieces of history and exam that distinguish these from each other and from tic disorders. We won't, however, cover any of the treatments of these because those are out of the scope of this, and I will discuss which ones need to be further evaluated by specialists. And there will be videos, so we'll be toggling back and forth between PowerPoint and the internet for some videos, illustrative cases. So the first case is a 6-year-old right-handed boy who presents to your office for evaluation of abnormal movements. And these movements have been noticed for some time, but are now bothersome to him. They're stiffening and twisting movement of mostly his right leg or right hand. They occur every day. They worsen as the day goes on, and the more he moves, the more they occur. They're now starting to cause him pain and interfere with his ability to do schoolwork and play soccer. And his father actually has similar movements. He cannot tell when the movements are going to happen. Does not have anxiety, ADHD, or obsessive compulsive behavior. His examination was remarkable for activity-dependent twisting movements of his arm. And he also has toe walking with rotation of the legs. No movements at rest. So when he's sitting there, he's still. So what does he have? So we will go and watch this young man. Oh. So you can see more movement in the right hand than the left, and his movements are uncoordinated. So the key thing is that this young man's movements are abnormal. When he tries to move, he has abnormal movements. He doesn't have any abnormal movements at rest. So he has dystonia. So dystonia is characterized by a hyperkinetic involuntary movement, whereas the muscles that both flex and extend a joint contract at the same time to induce a posture. And that's not what we see in tic disorders. It's activity dependent for most people. Therefore, it occurs with attempts at movement, not at rest. And tics, however, are present throughout, whether or not you're moving. And you actually tend to see them more when patients are still, as opposed to when they start to move. Like tic disorders, dystonia can run in families, but it does not have a strong relationship with ADHD, anxiety, or OCD as much as tic does. These patients absolutely need to be referred to a neurologist because they require evaluation and testing because dystonia is more of a symptom than a diagnosis. Okay, so case 2. 6-year-old right-handed boy presents to your office for evaluation of abnormal movements. Sounds familiar. These movements have presented rather suddenly and are bothersome to him. They're random flailing type movements of his arms and legs. He feels very restless and he's having changes in his speech. He's having problems articulating when he's trying to talk. These movements are present both at rest and with attempts at speech, and they're interfering with his ability to do schoolwork and karate. There's no family history of similar movements, and he has no idea when they're going to happen. Since the movements began, he has developed some anxiety and obsessive compulsive type behaviors. On exam, he has a new heart murmur. When you ask him to stick out his tongue, he cannot keep it out for more than a second or two. And on exam, he has random flailing movements that worsen when he's asked to sit still. So I'm going to go and show his movements. Looks like a nice young guy. You can see he's got this wiggling, writhing type movement. You can see when he holds his arms, you don't see a whole lot, but you can see when he looks at his leg, when he's trying to write, his legs do this twisting type movement. And he looks very, very restless. But you notice that most of his movements are below the head and neck. They don't involve the face and they don't make any sound. Okay. So these movements are in fact chorea, specifically with the history that I gave you of a heart murmur, new anxiety, and obsessive compulsive behavior. This is what's called Sydenham chorea. So Sydenham chorea is the most common cause of chorea in kids, often gets confused with Tourette or tic disorders because kids with Sydenham chorea can have new onset of anxiety and obsessive compulsive behavior. The key things in history, though, and the key things on exam are the Sydenham chorea, the movements are mostly of the body, arms and trunk. They're not usually of the face. The reason he has problems articulating is because if you watch him stick out his tongue, which it wasn't on the video, he has that same wild movement at chorea of his tongue. He does not, however, have any sniffing, snorting, throat clearing, any movements above the head and neck or at the head and neck, which are more characteristic of tic. So this is one that causes a lot of confusion, and we often get patients sent to us thinking it's tic, but turns out that it's Sydenham chorea. And you can see the chorea movement is more dramatic than tic. It looks like bad dancing. And the reason is the term chorea is actually derived from the Greek word choros, or for dance. The key things whenever you're seeing someone who's got extra movements and anxious, obsessive, compulsive, break out your stethoscope, listen to his or her heart or lungs. If you hear a heart murmur, that's a red flag. And the other thing is the tongue protrusion. The lack of inability to maintain tongue protrusion is not something you ever see in patients with tic disorders. You can't miss this disease. These patients require antibiotic prophylaxis because outside of the United States, rheumatic heart disease is the leading cause of heart valve replacement surgery in the world. So these folks must be referred to both neurology and infectious diseases. Okay, case 3. 6-month-old girl, this time, presents to your office for evaluation of abnormal movements. Movements have been present since infancy, but are really freaking the parents out. They're rapid, quick movements of both arms and occur exclusively as she is falling asleep. Her eyes don't open with these movements. There's no body stiffening. They do not bother her, nor do they even wake her up from sleep. Dad has similar movements that mom complains about all the time. He's normal development. On exam, he's completely normal with no abnormal movements. Parents bring the following video with them. Okay, so this is obviously not tic. This is sleep myoclonus. So very common sleep-related movement. Many people think this could be tic, however, the age is wrong. Tics don't present in infancy, they present later in childhood. These movements also occur only during sleep, whereas tics occur mostly during wakefulness. Sleep myoclonus can be rhythmic, as you saw, that little girl's arms were bouncing very wildly. Tics are not rhythmic. You can't set a beat to tic. This, like tic, runs in families, but the history is very different. Mom or dad, when falling asleep, once asleep, has a great deal of involuntary movements that disrupt the bed partner. These are not, however, myoclonic seizures. So when you see folks with this kind of movement, you worry, is this seizure? Seizures typically happen with eyes open, more upon awakening and as opposed to falling asleep, and typically happen in older children and teens. These kids need to be referred if there's no family history of similar movements, if the child has developmental delay, if the movements happen while awake, or if the movements begin to waken the child. So case 4, a 16-year-old right-handed young man presents to your office for abnormal movements. And these movements began the past couple months and are becoming more frequent and dramatic. They're characterized by fast, large amplitude, non-rhythmic movements of his upper extremities. They're tending to occur first thing in the morning and are coming in clusters. And he's actually throwing or dropping objects when they occur. Dad and aunt actually have the same movements, and he cannot tell when they're going to occur. Since the movements began, he's not noticed anything else. The movements are interfering with getting dressed and eating breakfast. His exam is completely normal, other than the movements that you're noted. Okay, and this, I think the bookmark closed. Here it is. Pardon the YouTube ad, but this is an important one because this often gets sent to us for tic. So watch the young man, the second young man from the left in the green shirt and the glasses. Okay, so you can see why some people, and this is one of the most frequent referrals that we get for possible tic. However, this is a much different condition and requires a much different treatment path. This is what's called juvenile myoclonic epilepsy. So those jerks that you saw, while very random, non-rhythmic, very tic-like, however, are actually seizures. And we get this referral multiple times a year that folks are like, hey, this teenage boy just started doing this, I think it's tic. The key thing presents in the teenage years, whereas tic tends to present sooner. These are brief seizures. They appear to preserve consciousness, but if you actually look at the EEG shows abnormal discharges throughout the entire brain, so consciousness is not preserved. The thing with myoclonic seizures, this example obviously was night because that was the best one that I could find that was reliable, but seizures classically occur first thing in the morning upon awakening. And unlike tic, people who have myoclonic seizures will drop things, throw things because they are completely dramatic involuntary movements caused by abnormal EEG activity. Most people who have tic do not have tics where they drop or throw things. And again, think about distribution. You saw that young man's body moving. It was all arms, no sounds, no facial movements, really not consistent with the distribution in the body of where tics typically occur. These patients absolutely positively have to be referred to a neurologist because they actually require lifelong anticonvulsant treatment therapy. Okay, case 5. 6-year-old boy presents to your office for evaluation of abnormal movements. They've been going on for years, characterized by rapid, disorganized, flailing type movements with any attempt at voluntary movement. They present throughout the day, worsen with stress, excitement, illness, or fatigue, and his mother and older brother have the same similar movements. He actually reports that he can tell that movements are going to happen before they happen. Since the movements began, no other symptoms have developed. They're starting to interfere with his ability to play. He sustained injury because they happened when he was trying to descend the stairs of the school bus, lost his balance, and fell face forward onto the ground. The story is a real patient of mine. The video is not. On examination, he has a few seconds of rapid, non-rhythmic movements of his body when he's trying to walk. Okay. So that is this guy. So you see these wild, sort of non-rhythmic, unusual movements. Okay. So this is what's called paroxysmal kinesiogenic dyskinesia, or PKD. This also gets sent to us very commonly thinking that it's tic, and it's great because they need a neurologist. So this is an autosomal dominant involuntary movement disorder. So it tends to run in families, just like tic. And you heard, mom and brother have the same thing, just like tic. However, the key thing on history is these movements occur when you're attempting to move, whereas tic typically happens whether you're moving or not. Additionally, like tic disorders, and this is one of the reasons this often gets confused with tic disorders, is these patients have a premonitory urge. It's different than the premonitory urge of Tourette or tic disorders, however. These patients describe sort of a rising feeling that starts in their legs and comes up their body before their movements happen. And you can see the distribution of the movements is mostly the legs. Okay, so very, very similar in history to tic, but completely different in terms of where the sensation is, because in patients with tics, the sensation to tic is usually involving the muscles that are involved in the tic. These kids must be referred to neurology because they can sustain injury, and they do require typically medication treatment. So case 6 is a 3-year-old right-handed boy presents for your office for evaluation of abnormal movements. The movements have been present since he was about a year old. They're becoming more frequent, more complex, more prolonged. They're characterized by rapid, rhythmic, repetitive handshaking movements, occur when he's excited, and now involve some sort of a facial scrunching and a grunting type sound. The movements do not bother him, do not cause him pain, and he can stop doing them when he is asked to do so. And he actually appears to enjoy doing the movements. Okay. Can you guys see me? Because I can't see if you can see my camera or not.
No, we can't. You can turn it on though.
Okay. So this is best demonstrated.
Here, I'll prompt you to share your camera, okay?
Perfect.
There we go. Oops.
Okay. So what happens this kid does this kind of stuff, and he does this, and he gets really into it. Okay, and you can shut my video back off.
Okay.
Okay, so this is one of the other movements that we get sent all the time, people thinking that it's tic. And it's because of the age, right? The fact that it's movements and sounds, and it involves the face, right? So it's the right age, the right distribution of movements. However, it's not tic. Okay. So these are complex motor stereotypies. So this is the pediatric onset movement difference that is the most similar to tic in terms of phenomenology, meaning it occurs in the right distribution of the body. It has both movement and sound frequently. The intensity of the movements is the same. However, these tend to occur only with excitement, whereas tics don't care whether you're excited or not. They typically show up earlier than tic, infancy, 1 to 2 years of age. And unlike tic, if you ask patients who have motor stereotypies to stop their movements, they can. When you ask them to do something else with their hands or arms, they can't. Whereas a patient with tic, you ask them to stop and say, they say, I can't. My body's telling me to do this. I have to move. So a stereotypy, you do not get that history. Stereotypies can be watched. They do not turn into anything else. They do not require any pharmacological therapy. They do not cause any long-term problem. They can be a source of social stress later in life, elementary school age, but for the most part, do not require any intervention. Okay. We're getting closer to tic. Okay. So neither of these have any video or demonstration. So a 14-year-old right-handed girl presents to your office for abnormal movement. Movements have been present for many months, however, they're rapidly worsening. And they're characterized by pulling of her hair on her scalp and her eyebrows and picking at her skin to the point of injury. She's terribly bothered and embarrassed by the fact that she's doing these movements. She feels she needs to pull her hair and pick her skin, and she gets relief from pulling and picking. In addition to these movements, she's incredibly anxious and has some obsessive compulsive type behaviors. There's also a very strong family history of anxiety and obsessive compulsive disorder. On exam, she actually has a bald patch on the top of her head where her hair has been pulled out. Half of her left eyebrow is present. She has no right eyebrow, and she has multiple scabs and scars of varying ages on her bilateral arms. She states that she only picks or pulls in order to relieve the urge to do so. So what is this? Is this tic? Is this OCD? Is it something else? So it's something else, but it's something else very closely related. So this is what's called body-focused repetitive behavior disorder. Specifically, this young woman has hair pulling disorder as well as excoriation disorder. So hair pulling disorder is just that. You pull your hair because you feel the urge to do so. You get relief when you do it, just like you would for tic. However, this is not a tic. This is a separate entity, but also in the same realm as obsessive compulsive type behaviors. And then excoriation disorder is skin picking disorder. So you feel compelled to pick your skin, you do it to the point of injury, picking your skin gives you relief, and just like tic, you're kind of embarrassed the fact that you're doing this. This is actually pretty common. So I have a lot of, and there's a ton of overlap here. So I have patient after patient after patient who has tic disorder and hair pulling disorder or excoriation disorder. So this is a very common thing that goes along with patients with tics. So you have to watch out for it. You have to look for it. It is, however, treated completely differently because this is a therapy-based approach to treat. This is not treated with medications. Good therapy is the mainstay of treatment and is highly successful, and it's completely different therapy than we use to treat tic. Okay, case 8. So we have a 14-year-old right-handed young man who presents to your office for abnormal movements. The movements have been present for 2 years and have greatly increased in frequency and severity. They're characterized by repetitively opening and closing doors, flipping light switches on and off, and opening and closing the refrigerator. These are incredibly bothersome to him. He desperately wants to stop doing this. He is annoyed and frustrated and embarrassed at the fact that he's doing it. There's a really strong family history that makes you think of tic, right? He's got family history of Tourette, anxiety, and obsessive compulsive disorder. He doesn't feel the movements before they start to happen. In addition to the movements in question, he's become increasingly cognitively rigid, insisting that things have to be done his way or they are wrong. His physical and neurologic exam is completely and totally normal, just like you would think for somebody with tic. The key thing here is during the interview. So he states that he has to do these movements either a certain way or a certain number of times. And he feels that certain numbers feel right, and he has to close the doors a certain way to get the best sound. And he feels if he doesn't do these movements in a certain way, something bad will happen. He has gotten to the point where he will do these over and over to the point where he's not able to leave the house and get to school in the morning because he's so entrenched into this having to be just right. Okay. So what does he have? He has obsessive compulsive disorder. Very common co-occurring feature with tic disorders and Tourette syndrome. The key differences, however, is the motivation for the repetitive behaviors. So with somebody with a tic disorder, they feel they have to do the movement to relieve that internal sensation of feeling of I have to do this movement. Whereas patients with OCD feel that they have to do the ritual in a certain way until it feels just right, or to prevent something bad from happening. Whereas there is not an internal sensation of something bad happening if you don't do your tics. You feel physically uncomfortable because the internal sensation to move is what patients in tics respond to, whereas in OCD, it's a thought process, okay? And they must be referred to psychiatry or psychology, or depending, even sometimes neurology, if you're in a situation like mine where we see a lot of patients with OCD as well. Okay, case 9. 10-year-old right-handed boy presents to your office for evaluation of abnormal movements. They've been present for at least 5 years. They're constantly changing. Started with eye blinking and throat clearing, and presently he has a rapid neck extension movement and a humming type sound. They're bothersome to him. They interfere with life. They're present all day long. No matter what he's doing, they are there. They worsen with stress, but they seem to disappear when he's either playing his trombone or he's on the basketball court. Father and sister have similar movements, and he feels the movements before they happen. With his neck, he says, it feels like there's just something in the back of my neck that makes me want to fling my neck backwards really fast. And, after I do that, that feeling of needing to move my neck goes away for like a minute or two, but then it comes back. So in addition to these movements, he's having a decline in his grades. He's become very emotionally sensitive and is increasingly anxious. His family history is remarkable for ADHD, anxiety, OCD, and Tourette. And on exam, he has a rapid, non-rhythmic neck extension movement, as well as some intermittent throat clearing and humming. And he says, Dr. Coffman, I don't know what's going on. My movements are worse today than they ever are. I don't know why that's the case. So what does he have? So this young man has Tourette. So he has movements and sounds longer than a calendar year, before the age of 18, not due to another medication. When we think about who develops tics, typical age 3 to 15 for the most part, with a small portion starting about age 18 and older. Incredibly common, as you may all know, and if not, 20 to 60 per 1,000, whereas Tourette syndrome and chronic tic disorder combined is about a 1% of the population. And as you could see, other than the 14-year-old girl with the excoriation disorder and the little girl with the sleep myoclonus, I set this up so that everybody was a boy, and it's because the fact that 3 to 4 out of every 5 people who has tic disorders are young men. The key things when you're trying to sort out tic versus other things is tic can look and sound like just about anything. Okay, you have to remember when you're trying to say, okay, is this tic or something else? Involuntary movement. So that's when you separate out your stereotypies. When you ask your kid with stereotypies, do you know you're doing these movements? Yeah. Do you like doing these movements? Oh yeah, it feels great whenever I'm doing that. I really don't like it when mom asks me to stop. That's how you know stereotypy versus tic. Because you ask a kid with tic, do you know you're doing this? Younger kids are going to say, no, I have no idea I'm doing it. I don't know what you're talking about. Then you ask an older child with tic, hey, do you know you're doing this? Yes, and I wish I could stop. It's driving me crazy. That's how you sort out stereotypy versus tic. You have to remember that tics, for the most part, occur head and neck. So eye blinking, face twitching, grimacing, neck jerking, okay? Complex motor tics, which we didn't touch on because I wanted to really tease out what to think about with tic versus other things. These are more unusual, complex movements. Common vocal tics, right? Sniffing, snorting, throat clearing, yipping, yelping, grunting. So when we think about, is it tic versus any of these other movements, do they make sounds? So most patients with tics will have both movements and sounds. As you saw, the only other one that has sounds was stereotypy, but you sort that out from tic by knowing that it's rhythmic and the patient wants to do it. Complex vocal tics, where you express words or phrases or repeat yourself or echo yourself or echo somebody else. We didn't touch on again because the fact that there's not as much overlay. I would have, if I had given you that history, it would have been very easy. So, and how to sort out tics versus these other movements. So tics are predictable. So patients with tics can tell you, if I do this, I do that, I know it's going to happen. So that's where the overlap is with the paroxysmal dyskinesias. They know if they do something, they're going to have their movements. However, the key is their movements are triggered exclusively by activity, whereas someone with tic will say, yeah, if I'm sitting in English class, I know I'm going to tic a lot more than I do in math class because the teacher really stresses me out. You're not going to get that for someone with a paroxysmal dyskinesia. With the patient with dystonia, he doesn't know when his movements are going to happen. He hasn't been able to figure out sort of what triggers it. And the young man with the myoclonic seizures, his seizures happen with no predictability for him. Okay. The other key thing in trying to sort out, is this tic versus another movement? Can the patient suppress it? Right. So each one of these other conditions that I covered, the only other one that is suppressible is stereotypy, but that's really you stop it as opposed to suppressing it. You can't keep yourself from having dystonia. You can't keep yourself from having dyskinesia. You can't keep yourself, obviously, from having seizure. And you can't keep yourself from having chorea. So that's the other thing when you're taking a history and trying to figure out which is, can the child stop the movement? Tics are distractible. So you heard me in the talk about the young man with tic. If he's playing his musical instrument or he's on the basketball court, the movements disappear. This is the only one of the movements that we often get sent looking like tic that have that history. And then tics, for the most part, disappear during sleep. You saw the young man with the dyskinesia and the little girl with the myoclonus. Their movements were going on during sleep. Okay, seizures will also occur during sleep, whereas tics, compared to most of these others, don't. So tics will worsen with stress, excitement, fatigue, or illness. So that's true of most neurologic conditions. So you can't really hang your hat on that one at all in trying to sort it out. However, you can hang your hat on the premonitory urge. So premonitory urge is that thing that that happens before you feel like you have to tic, that your body's telling you you have to move, need to move. Okay. You also see it with paroxysmal dyskinesia, but it's a different problem, right? It starts in the leg and comes up, whereas the premonitory urge for tic is involving the muscles that are involved in the tic movement. And sorting out premonitory urge from OCD is, it's the feeling in my body that tells me I need to move, as opposed to thought in my head that tells me I have to open and close the door a certain way. Tics are suggestible. So this is one of those that I use all the time in clinical practice. If I'm seeing someone I'm not sure by history whether it's stereotypy or tic, because there can be a whole lot of overlap in terms of the age. And if the stereotypies aren't complex yet, you may sit and scratch your head. Even I, as a movement disorders neurologist, like, I'm not sure which this is based on the history. So what you do is you demonstrate tics. Tics are so suggestible that if somebody's got a tic disorder and you start demonstrating multiple tics, they're going to start doing those tics. That is only true of all these conditions we talked about. That is only true of tic disorders. Here's where it gets tricky when it comes to tic. Is this tic or is this a compulsion? There's a great deal of overlap between tics and compulsions, and we know that there's a great deal of overlap in terms of tics and obsessive compulsive disorder. Okay. If you have an obsessive compulsive component to your tic, you have to do your movement a certain way or a certain number of times until it feels just right. But then you go back to the urge. Do you feel that you have to do this movement to prevent something bad from happening? Or do you have to do it this number of times and you don't know why you have to do it this number of times? And that's my question, is do you have to do it this way, but you don't know why? Or do you have to do it this way or something bad will happen? And if they say, I don't know why, then tic versus OCD. Okay. When we think about tic disorders, we already talked about the co-occurring features. So other things, if you're seeing someone and trying to figure out, is it tic versus another movement problem, go for sleep history. So kids with tic disorders have very high rates of restless leg syndrome. So this is characterized by a sort of itchy, mildly painful feeling on the legs that if you rub your legs sort of makes it feel better. Restless leg syndrome is caused by total body iron deficiency. Tic disorder patients tend to be very picky eaters when it comes to food textures. So they don't eat a whole lot of things that have iron, like dark leafy green vegetables or red meat. Sleepwalking, sleep talking goes along with tic disorders, and they're not things that typically go along with the other movement disorders we discussed today. Executive function deficits, so failing to execute a three-step task. The only other overlap you're going to get there are the patients with epilepsy if their seizures are not controlled, but none of the rest of those disorders are going to have problems with executive function. Learning disabilities, again, in epilepsy, you're going to see some overlap, but the fact of the totally different presentation should help you sort that out. Dysgraphia, poor handwriting. Obviously, the young man with dystonia, because he can't really use his hands very well, is going to have poor handwriting, but then you go back to the distribution of where are the movements. And the young man with chorea, you saw he was trying to write and his body was flailing and twisting. Again, you go back to distribution of movements to say, okay, that's chorea, that's not tic. And then hoarding, compulsive collecting, the only overlap you're going to get between tic disorders there is patients with OCD. So my take-home points, there are a wide variety of movement conditions that present in the pediatric and adolescent ages. Context is key. Certain things travel together for a reason. And if you sit and take the time to get the good history, you're going to not miss these conditions and get folks the right diagnosis early on. And just like I showed you, the words don't do these movement disorders justice, which is why whenever you're thinking about someone with a hyperkinetic involuntary movement, in today's day and age, you've got to get video. Video answers everything whenever it comes to the patients that I see in my office. Here is the staff of our Tourette Syndrome Center. That is the view of Union Station, our train station downtown, and that is the front of Children's Mercy, and I am done.
Okay. Thank you very much, Dr. Coffman, for that presentation. Let's see. We will now begin our Q&A session, and I will be reading off those questions to you. If for some reason we're unable to get to your question during this presentation, we will be reaching out to you through email. If you have a more urgent matter, you can contact the association directly at support@tourette.org. Again, that's support@tourette.org. Or you can give us a call at 1-888-4-TOURETTE. That's TOURET. Okay, Dr. Kaufman, first question comes from Chris S. Let's see, in this particular scenario, there is a 12-year-old boy, server full body movements, which are violent at times, happen every 3 to 5 minutes with tic attacks at times, will throw food, will shout, swear, open mouth wide, no precursive feeling, lost use of legs totally for 8 weeks, but since removed. Let's see, has been diagnosed as Tourette, but not responding to aripiprazole. Any ideas?
So, yeah, given the complexity of the presentation, given the a loss of use of limbs for a period of time, this is a situation where one has to consider that this may be a functional neurologic disorder, so also previously called conversion disorder. When you have an incredibly complex presentation that doesn't respond to treatment, and the symptoms continue, so loss of ability to move legs is not a feature of Tourette. So yeah, this is someone who deserves an evaluation for possible functional neurological disorder.
Okay. The next question comes from Lisa D. Can chorea/ARF be a comorbid with coexisting with other movement disorders like Tourette syndrome?
So yes. So rheumatic fever is an autoimmune response to having had a streptococcal infection. Having another condition does not preclude you from also developing rheumatic fever. In the 17 years that I've been taking care of patients with tic disorders, I have not yet encountered anyone who has had both, but theoretically and medically, yes, it is possible. I've just not had anybody come through my door who has that. There's no reason that you couldn't have both.
Okay, the next question comes from Danielle R. I have a client who grabs, throws, and sometimes dumps food on themselves. What? They're saying that they have tics or grabby, they have tics that are grabby when that happens. Can these be tic behaviors?
I would have to see video of that. So most of the time, okay, so as a general rule, tics don't have a purpose. Tics don't do anything that are purposeful. When I tell people about tic disorders, sort of they don't fit the situation, right? So that sounds like a stretch, but I would really have to see some video to better understand. But I'd be suspicious for maybe not tic based on what I'm hearing.
Okay. The next question comes from Heather Ramsey. Is executive dysfunction a feature of Tourette?
So it is, but by the textbook definition of Tourette, which is the presence of at least one movement and one sound longer than a calendar year, it is not part of the definition, but when you look at things that occur in high frequency in patients with tic and Tourette Yes, executive function deficits are very, very common in patients who have tic disorders as a co-occurring feature.
Okay. The next question comes from Lisa D. Is sleep myoclonus RT restless legs? Can this be associated with iron deficiency? In infants, how can myoclonus be differentiated from infantile spasms?
Okay, so there are two questions there. Sleep myoclonus in relationship to restless leg. The two are separate. Sleep myoclonus tends to run in families, whereas restless leg doesn't usually have a strong family history. Sleep myoclonus is not related in any way, shape, or form to iron deficiency, whereas restless leg syndrome is a byproduct of iron deficiency. Sleep myoclonus versus infantile spasms. So the history for infantile spasms is typically a movement whereby the child, upon awakening, but can occur other times during the day, has movements characterized by the head dropping forwards and the arms raising up tonically at the same time, whereas sleep myoclonus, as I showed you, is not a tonic movement, it's a twitching movement. Infantile spasms, which are now called epileptic spasms, in the latest iteration of the definition, they got rid of the word infantile because they can occur at other times other than infancy. So epileptic spasms also tend to cluster, whereas sleep myoclonus does not as much cluster. The other thing, and the key thing, and why I put it up on the slide, is any developmental delay or loss of developmental progress, which is what you always see in epileptic spasms. So because what happens in epileptic spasms neurologically is a very disorganized brain activity called hypsarrhythmia. Development stops, development regresses, whereas you do not have that in sleep myoclonus. And that's one of the reasons that if you have something that you see in a child that you think could be concerning for seizure, and you have a history of developmental impairment or sudden loss of developmental progress or developmental regression, that's why you need to send that child to a neurologist to be evaluated for epilepsy. Perfect, great question.
Okay, and the next one comes from Claude S. How close are we to an MRI or EEG test that can reliably diagnose among these disorders?
So the only one of these disorders that is diagnosable by EEG is juvenile myoclonic epilepsy. When it comes to diagnosing movement disorders, my first slide after the disclosure was that neurology is all about history, right? So movement disorders neurology is at this point in time an imperfect science because it is based on exam and clinical history. There aren't biomarkers for these conditions like EEG or MRI. Now, out of the scope of the talk, but given the question was asked, for conditions like paroxysmal dyskinesia and chorea and dystonia, there are other tests that need to be done in those conditions to try to figure out why those movements are happening. But again, with all of those conditions, for the most part, MRI and EEG are going to be wastes of money. They're just not going to give you your answer.
Okay, thank you. The next question comes from Deborah L. The slide states dysgraphia with tics does not improve with OT. Why is that?
So we're not really sure. It appears, scientifically speaking, it appears that it's a more hardwired problem with probably visual motor integration as opposed to fine motor control, because fine motor deficits are not one of the classic hallmark features that you see in patients with tics, yet dysgraphia is. So it's probably more a problem of visual motor integration, which is why OT is unfrustrating, or very frustratingly, typically unhelpful.
Okay, the next question comes from Jacqueline P. What about pandas? How can you differentiate pandas from Tourette, or can they coexist?
So pandas, so you notice I did not cover pandas, and the reason I didn't cover pandas because it is a topic in and of itself. When you look at tic disorders and pandas, the TAA released a statement either last year or earlier this year about the relationship between pandas, PANS, and tic disorders. And at this point in time, there's not sufficient scientific evidence to link pandas or PANS to tic disorders or Tourette syndrome. So that's why I didn't cover it, because there isn't scientifically a relationship strong enough to talk about. And if you would like more details, the statement about the relationship is on the TAA's website, tourette.org.
Okay. And the next question comes from Heather R. once again. Is Tourette a disorder of disinhibition?
Yes. Yes. So when we think about the phenomenology of tic, it is a problem of disinhibition, and the disinhibition occurs, we believe, based on everything we know, within the basal ganglia, and that is why the extra movements slip through the basal ganglia and show up as tic. And that is why when you look at other things that go along with tic, anxious, obsessive compulsive, sensory processing, there are also problems with disinhibition. So yeah, Tourette is a sort of prototypical problem of disinhibition within the brain, below the level of MRI detection.
Okay. And the final question comes from Nick S. How can someone have both OCD and Tourette?
So OCD and Tourette occur incredibly commonly. So all of the literature is really converging to say that if you look at all patients with Tourette at the population level, the rate of co-occurring neuropsychiatric conditions, and those include ADHD, OCD, anxiety, and intermittent explosive behavior. So if you look at those four, 86% of patients with Tourette will have at least one of those four conditions. 66% will have two or more. And this is data that was published first by Dr. Carol Matthews and her research group back in 2015. And when you look at which of those four conditions are the most common, OCD and Tourette have about the strongest relationship. At about 60% of folks with Tourette will have OCD, depending on which research study you read, and about 50 to 60% of patients with Tourette will also have ADHD. Now, the real trick comes into when you have patients who have both, trying to figure out, is something they're doing a compulsion or is it a tic? And that is why, our Tourette Center has the combined team of both psychiatry and neurology, because sometimes it takes both the psychiatrist and the neurologist sitting in the room with the patient and the family talking at the same time to figure out the intricacies of, is it a tic or is it a compulsion? Because the two are treated so completely differently that if you try to treat a tic like you do a compulsion and vice versa, you don't get anywhere. So that's where the really the art of understanding Tourette and OCD really comes into play at that point.
Okay, and my apologies, there is one more. It comes from Deborah L. Can you review the difference between TD and tics, especially if the person has been treated for neuroleptics or with neuroleptics?
Sorry. So by TD and neuroleptics, I'm deducing that you're talking about tardive dyskinesia. So tardive dyskinesia is characterized by repetitive sort of grimacing movements of the mouth, often with profound tongue protrusion, and you see what's called orobuccal lingual dyskinesia. So oro mouth, buccal lip, lingual tongue. So you see these very fast, non-stop movements that don't make any sound other than just the natural sound of that you get with opening and closing. The other thing with tardive dyskinesia is the history, right? So tics don't arise from being treated with neuroleptic medications. And for those of you, so neuroleptics are also known as antipsychotics, and they are medications that block dopamine receptors. And tardive dyskinesia results from sort of too prolonged or too high of a prolongation in terms of dose of dopamine receptors. So you get this dyskinetic movement because of the medications you're on. So it's also all about history. And then it gets into exam. So if you've seen dyskinetic tardive dyskinesia movements, you know very clearly what those look like versus tic, just based on watching even 5 to 10 seconds of somebody for the most part.
Okay. Thank you so much for a wonderful presentation, Dr. Coffman. This is all the time that we have for this session. Once the session is closed, you will receive a survey on this presentation. We would love to hear your feedback. We would greatly appreciate if you would complete and provide your feedback as well. You will receive a follow-up email in 24 to 48 hours with the link for you to review this webinar. Additionally, the webinar will be posted to TAA's YouTube channel for those who are unable to participate, so please share with your friends and family. We encourage you to reach out to us about this webinar or other resources and opportunities to connect. On behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. This presentation was presented free of charge thanks to our generous donors. If you appreciated this session, we welcome you to support the organization. May 15th starts Tourette Awareness Month, and we welcome everyone to get out and get active through Miles for Tourette. Visit us at tourette.org to learn more and give. Have a good night, everyone.